across, you have visited the different states of Northeast and even the interior parts. What is the status of the non-communicable diseases there, number one? The second part of my question is, what are the strategies that can be adopted to overcome these challenges?
I'm privileged to be midst of the august panelists and all the audience. And last 50 years, India has been struggling with the communicable diseases, infectious diseases. But for last 25 years, India is struggling with non-communicable diseases. More than 65% today in the healthcare facilities are dealing with non-communicable disease, which includes cancer, very, very common in northeastern India, and places like Mizoram and Arunachal Pradesh and Assam is leading, and hypertension, heart diseases, diabetic is very rising, and also other communicable disease like lot of social related issue. We have a Joint Secretary Government of India is sitting here. Drug related issues we have seen, drug addicts. I think very high proportion of, it also includes psychosomatic and mental diseases leading to, and alcoholism. These are the few things which region is really today struggling with these non-communicable diseases emerging. And when you look around, if the facilities looking around, with my experience working for last 45 years in public health and different positions, as Dr. Jeet has said, when I was an advisor health to the Government of India for NEC, gone around whole of 8 states. And when I became a regional director, RRC, that is looking after the National Health Mission, I think I have visited almost all the hospitals in the northeastern India. And we have seen that to deal with these non-communicable diseases, the facilities we have, health infrastructure we have, human resources we have, and also budgetary support we have, I think is very much inadequate. And in fact, we don't have a hospital with the due permission from some of the major players like Dr. Palin sitting here, Dr. Nalin Mehta, who is the director of NIGRIM, with due apology from them. None of our institute today is in a position to deal with all cases, and especially tertiary care cases. I think fractionally they have a very good experts, and we are not in a position to deal and address the issues of the non-communicable diseases like cancer, and for which I think still we have to go to the out of the northeastern India, and out-of-pocket expenditure has mounted. When I was in Advisor Health Northeastern Council, I did a very brisk, survey from the government system itself. 10 years back, the northeastern state, all the 8 states, they used to spend around 500 crores rupees every year for undergoing the treatment outside the northeastern India. That only from government system, and what about the private system? So it is you can again say around 500 to 600 crores rupees. I think it's a huge amount we are sending out and depleting our economic status, and the circulation of money in the market has been deprived, and hence it brings down the, poverty-related issues in northeastern India. This is a major issue, and though I think infrastructure has been developed to deal with like cancer, we have a regional cancer institutes, and as per the National Cancer Control Program, every state must have a cancer hospital, every district must have a cancer wing. I think with my assessment, we could not do it. And issue of the cardiac related, like hypertension or kidney diseases, and all these issues, we are not able to tackle effectively. And still we have a long way to go to meet the aspiration of the people of our northeastern India. Thank you so much.
When it comes to the communicable diseases, tuberculosis is one of the major problem in the country. With the national anti-TB programs, the government of India has launched. But at the end of the day, especially in the northeastern region where we fall short of achieving those targets. And this is one of the main reasons why the awareness is not there. Now, the patients come at a later stage where, they come with deformities when it comes to the TB spine. They come with many issues, complications. Multi-drug resistance is one of the major issues when it comes to the TB patients. My next question is for Dr. Tonkeswar Borua. He's an orthopedic and spine surgeon. So what are the difficulties or the deformities that the patient might have when the patient comes at a later stage? Number one. Number two, what as medical or healthcare provider, what are the initiatives that can be taken from our side to make people aware that the cases are detected early, sent to the appropriate center at the appropriate time, and the treatment is continued?
Thank you. And very pertinent questions. And first of all, I also want to convey my best regards and thanks to the organizers to invite me to be amongst the very prestigious panelists. And tuberculosis, yes, we know that Government of India is going with a robust program to eliminate tuberculosis from India. Like we eliminated polio from India, and also we could handle our corona program very nicely in India. So why not we cannot eliminate tuberculosis from India? Now, for pulmonary TB, dot centers are available in every dispensaries or every corners of the country and doing good. But the treatment of extrapulmonary tuberculosis, which we know the systems which are out of lungs involvement, the detection is very late usually because people don't know how to detect these symptoms. Now, out of the other systems, musculoskeletal, the subject in where I am working, orthopedics and spine, it is mostly involved. And out of them, spine is very commonly involved. Now, the people usually come late to the hospitals with some kind of paralysis or some deformity in the spine. So, my recommendation would be people should, the primary health caregivers, they should know how to detect not only lungs TB or pulmonary tuberculosis, they should know how to detect the other things because spine tuberculosis is very severe kind. So any patient who is having back pain, which is not relieved by any kind of conservative treatment, or if the person had some contact of tuberculosis in the family or in relations or vicinity, or he had history of past tuberculosis, they should immediately refer to the patients to the tertiary care centers, preferably medical colleges. Now, working in Safdarjung Hospital, which is one of the, I think, biggest hospitals under the Government of India. So lots of patients, they come from other states like Bihar, UP or nearby states. Even some patients, they come from Assam also, as I am working here. So treatment is there when we intervene in right time or even in late cases also. I had lots of patients who has severe paralysis or deformity of the spine, but if you give treatment to those patients, if you don't neglect those patients, if you don't refer those patients, they are not going to get treatment at any way. So these patients, almost 90% patients, they got recovered. And last one point, the medications. Many of the patients or doctors, they prescribe the medications from the chemist shops. But my special recommendation in last 10 years of experience in Safdarjung Hospital, not a single patient I had prescribed a single medicine from outside. And all patients, almost 95% patients which I am following, they had recovered the tuberculosis medicines which had been provided by Government of India. So I request all to prescribe and encourage to take medicines from the Government of India. Yes, thank you.
Now, when it comes to TB spine,
Yeah.
the biggest confusion that the general public faces is whom to approach, an orthopedic surgeon or a neurosurgeon?
Okay, very good questions. So a small example, I was working in Fortis Hospital. One of my cousin who is nurse, and she sent her husband to be operated by our team. Now, just before entering the OT, she had called me from Assam, asked me in Assamese language, are you taking any neurosurgeon with you? I just scolded her, don't worry, I am there, but if you want, I will take. So there's lots of confusion where these patients should be, any spine patient should be dealt by, whether it is neurosurgeon or orthopedic surgeon. But to my knowledge, being an orthopedic surgeon, it is the work of both the team. The person who is having substantial experience in spine, dealing spine surgeries, they should go for any, whether it is orthopedic surgeons or neurosurgeons. And last one comment, please, we should have designated spine care centers at least at zonal basis like Dibrugarh, Itanagar or any northeastern states. That is my special suggestion to the Government of India. Thank you.
Thank you. The next part is we are going to discuss about the infrastructure in the Northeast. My question to Dr. Palin. Dr. Palin runs a multi-super specialty hospital in Imphal, one of the best hospitals in the Northeast, and also NABH accredited medical college, which is the first in the Northeast. Sir, from your experience, what are the infrastructure gaps that we see in the healthcare institutes across Northeast? Number one. Number two, what strategic initiatives can be taken by the government to address these gaps?
Thank you very much for giving me the opportunity. In fact, Caesar Hospital started as a monopractice, become a super specialty hospital, then ultimately the first homegrown private medical college in northern India. In fact, for us, inconveniences are the root cause of our success, because we had all the inconveniences required for success in the turbulent environment in Manipur. And the first gap we have observed in the northern India is the urban concentration of the modern hospitals. 70 to 80% of the hospitals are located in the urban areas. So those in the rural area, they cannot get access to the health care, especially the secondary or tertiary care. They have to come all the way. And also because of the hilly terrain and the wet road, very difficult to reach to the hospital. Sometimes they die on the way also. Number two is quality assurance. World Health Organization has already announced that avoidable medical errors are the third cause of death in the world. And India has got our own quality assurance, NABL and NABH. Number of NABH and NABL are very less in northern India, and there is no one JCI, the Joint Commission International. There is no such hospital in the northern India. We have to increase through the government policy the quality assurance, because safety is primary, and distance is not a barrier. We can develop northern India is the healthcare tourism destination of the world. They can come once we can provide the best and the safest healthcare. And another is there is a lack of insurance. All the vehicles, 100% of the vehicles are insured, but not the human being. So 37% of Indians are insured, and 70% under government, like PMJ or Chief Minister insurance or central government health scheme. But the problem is the cost is very low, and particularly for the private hospital, it is not sufficient. Out-of-pocket expenditure is there. Mental health, there is no access. There is a lot of difficulties, particularly for the drug abuse and the other mental health, because it is also increasing. Another thing is the profitability, because the population expect the best treatment. But in order to establish a modern hospital, accredited hospital, it is costly and the interest rate is very high. Here, Unnati, this Northern India, this industrial policy it has come into effective. So this is going to help us with a central capital subsidy and also interest 5% interest subsidy. That is going to be very, very useful. Another thing is medical, nursing, and paramedic. A lot of students are going outside the state, and huge expenditure. And demand is there from Japan. 35,000 nurses they are demanding, and also most of the metro hospital, the nursing population from Manipur is about 20 to 30%, and probably Manipur is producing the highest number of nurses next to Kerala, and this can also be enhanced with the help of the government. And in our experience, we have been able to establish a medical college. According to the guideline of NMC also, we have to adopt villages, because the whole issue is how to give the access of the healthcare to the mass, particularly in the rural area. So we are, because of being the medical college, we are going to start a free OPD throughout, and telemedicine outreach program regularly is being conducted, and some of the villages will be adopted. These are few things we have, and particularly with the help of government, we can do many things like a district hospital on PPP mode, because PMJ is there, CMSC is there, so we can public sector can go into the village and establish in the district hospital on PPP mode. That is how we can provide the services to the mass. Instead of coming to the town or this metros, we can provide service because of this insurance, small insurance from the government. That is how we can provide.
Thank you, sir. You mentioned about patient safety and the quality in healthcare just in your discussion. Now, when it comes to the patient safety and the quality in healthcare, medical error is the third major killer in the US. In India, it is not, because we do not have a system of capturing the data, number one. The incident reporting system is not here in India. Now, with the introduction of National Accreditation Board for Hospitals and Healthcare Providers, and by the Quality Council of India, the NABH, and the NQAS standards by the National Health Systems Resource Center, these systems have slowly or gradually started, but we are yet to, have a system where incidents are reported and medical errors can be prevented. Now, my next...
Just one, Caesar Hospital is the first NABH accredited medical college hospital in Northern India, and second in Eastern India for the entire 12 states. Thank you.
One of the major aspects in when we talk about healthcare, we are encompassing the different segments, is the other systems of medicine apart from allopathy, where Ayurveda is one of the major streams. Now, my next question to you is how Ayush can be integrated in the mainstream of patient care delivery, number one, and what are the opportunities which are there in the Northeast which can be tapped?
Very good evening. First of all, I am very much honored to be a part of Ashtalakshmi program, and that too sitting among so many renowned panelists. So, namaskar. Okay, coming to the first part of the question, actually, Ayush is a combination of 5 systems: Ayurveda, Yoga, Unani, Siddha, and Homeopathy. So, so mainstreaming is 5 system, you know. First and foremost, we have to create a national and regional framework so that both Ayush and conventional system of medicine can work in synergy. We have to create a space for the Ayush professionals so that they get a chance to show their expertise along with the conventional system doctors through their indigenous medicine. Second, we have to have a collaborative approach along with modern medicine. Collaboration in the sense that we have to complement each other. As a Ayush professional, I cannot deny the fact that we are not the masters of all the diseases in the world. But we are doing commendable works in the field of non-communicable diseases, even in the field of de-addiction, benign endorectal diseases, etc. So if there is a system of cost referral, then we can approach towards a holistic healthcare. And the third point is that capacity building and training of Ayush doctors. They have to train in such a way that they get all the knowledge regarding modern medical advancement, regarding modern diagnostic tools, so that they can use their traditional wisdom along with their modern tools and diagnostics. And the fourth is infrastructure. Infrastructure part is very important. Actually, in every hospitals, there should be Ayush integrated services, so that every rural and urban population, they get access to Ayush medicines or Ayush services. And the fourth part is government support and funding. Government support means in the sense that more Ayush professionals should be recruited in the government sectors. Again, there should be continuous supply of quality drugs and production of Ayush drugs. And next, we have to take the help of technology also. Actually, like telemedicine, through which people can directly come in contact with Ayush professionals, and where they cannot access Ayush healthcare facilities, or we can develop apps, mobile apps, where we can disseminate regarding Ayush healthcare facility, regarding benefits of Ayush. And the last part is that we have to be a part of all public health campaigns, so that we can promote Ayush everywhere and people get to know about Ayush.
Now, Government of India has taken initiatives. Now, Ayush OPDs are there in the primary health centers and even the smaller health centers. Yes. Where, you know, recently I visited a place called Panbang in Bhutan, where wherever I go, I always make it a point that I visit hospitals. I saw a signage that hospital is this side. I went and visited. They have the allopathy system, and one segment is typically for the Ayurveda system, and they have a complete full-fledged kind of an OPD and a referral center. And like the way you mentioned, that cross-referrals are very, very important. We as allopathy, from the professionals from the allopathy stream, we should understand that at one point of time, the patient has to be referred to another system. That is the cut point where we really have to draw a line and understand.
Yes,
right? Now, in that case only, I think the things can be integrated properly.
Yes, sir.
What we see in healthcare is that education and research is one of the major mainstays. Until and unless we have the manpower. Now, the different governments in the northeastern states have come up with many infrastructure. Setting up hospitals, setting up medical colleges, setting up other healthcare amenities. The biggest problem that we face is the lack of manpower. Especially, the entire world is suffering from the lack of manpower. As per the National Sample Survey Organization, a study was done where the paramedic professionals, there was a lack of 67.2 lakhs of deficits across the country. Now, especially in the Northeast, the figure is even more. The ratio is even more. Now, in that case, education is one of the major mainstays. Now, again, the research part, where you visit any hospital in the Northeast, so-and-so hospital, private limited, and research center, and I hardly see that when you talk to the promoters, how many research papers that you have come up with in the last few years. They said, no, we haven't done yet. Maybe they are running for decades with that tag of research center, but none is happening. One of the one of the most important institute in the Northeast is Northeast Indira Gandhi Regional Institute of Health and Medical Sciences. We call it NEGRIMS in Shillong, which is one of the best educational training centers, a medical college, and the postgraduate and the undergraduate and the nursing and the paramedic school colleges. So my next question to you, Dr. Nalin Mehta, sir, is what, as NEGRIMS, you being the director, what are the initiatives taken by NEGRIMS? The name itself says Northeast. What are the initiatives taken by NEGRIMS for the Northeast to develop and address these issues?
First of all, my gratitude to the organizers for this wonderful event. My gratitude to the organizers for having organized this wonderful event, which touches across all fields. Now we are now down to the last but not the least in terms of healthcare. And thank you. That was a very pertinent question. NEGRIMS was established in the northeastern region to serve the entire region. We have an undergraduate medical college with postgraduate courses. It's a tertiary care hospital, and it has the trinity of vision: teaching, healthcare delivery, and research. And the MBBS course there offers seats for all the northeastern states. So we have a quota for different northeastern states. And as and when the different northeastern states have become, competent and have their own capacity and their own medical colleges, those quotas have been reduced or removed. For example, Manipur has a couple of medical colleges. And very recently, Mizoram was excluded from that quota because they have their own medical college. So I'm very happy to note that most institutions are coming up in different states of the Northeast. Now, capacity building is one of our biggest fortes. If you go across any institution in the Northeast, a lot of graduates and postgraduates who are currently faculty, whether it is in Itanagar, Naharlagun, that TRIMS, even in Manipur, though Manipur has a very good institution, the Regional Institute of Medical Sciences at Imphal. In Mizoram, Tripura, we have our graduates and postgraduates who are currently serving in most places, including our nursing staff. And collaboration with the state government has been one of our strong points. We address the unique requirements of the Northeast in three ways. One is to train and send manpower, not just doctors, even technicians, nurses, paramedical staff. We have multiple courses. Through the National Medical Commission, we are also the designated nodal center for medical education technology. So as is the requirement, every faculty in most institutions have to go through advanced and basic medical education courses. So NEGRIMS trains the faculty of the entire region, sharing it with some who are designated to Dibrugarh. And we also train people from West Bengal. There are colleges that are allotted to us. So we train their faculty, residents. Apart from the technical and the nursing staff that we train, we address, for example, with the state government, we have their health services in Meghalaya. We train their staff, especially in cancer care and in developing skills for most laboratory techniques. We are the nodal center for diagnosis. We are the nodal, even for COVID. So we have a whole bunch of facilities where we keep it open to the state health workers. We also get trainee doctors from TRIMS. We have an MOU with them for training them for their DNB courses. Some of the postgraduates who come to us for super specialties like cardiology, neurosurgery, etc. So our doors are open to the entire Northeast. And we also carry on collaborative research. In fact, we have a very robust, and I would be very proud of the kind of research output we have. And we have tremendous number of projects from DBT, DST, and ICMR. And we are contributing a whole lot of policies that are being developed out of the results from our research carried out in NEGRIMS, which covers the entire region. Now, apart from that, we address the main causes of concern in the region. One is cancer. In fact, Meghalaya is the cancer capital for esophageal cancer. So we have a regional cancer center, which has recently come up. In fact, it was inaugurated on the 14th of October last year by the Honorable, the then Health Minister, Shri Mansukh Mandaviya. And this is a 252-bedded facility. We have the LINAC, we have the state-of-art facilities, CD stimulator. So we offer medical, surgical, and radiation oncology. We are addressing cancer. The communicable diseases are now on the, non-communicable diseases are on the rise. We see a lot of kidney ailments, diabetes. Some of these issues, we see patients leaving the state and going out for treatment. But our endeavor is to expand, recruit and retain faculty so that we can offer care to all the patients that do not have to leave the state. And not just the state. We are running all the insurance schemes, even for Arunachal, the Chief Minister scheme. So also for Nagaland, PMJ, the Meghalaya Health Insurance Scheme. So we offer a lot of cashless schemes to patients from the entire region. And we also get patients very regularly from the neighboring countries, mostly from Bangladesh and a few from Burma. So I think overall, NIGRIMS is addressing the health needs of the entire region. But to my mind, we need to do more. I wouldn't say that we are doing enough to cater to the entire requirement, as was mentioned. We are still expanding, we still have scope for improvement and to provide better service to the entire region. Thank you.
Thank you, sir. Now, when it comes to healthcare, the 3 or 4 A's, availability, accessibility, the affordability. These are the 3 A's which are very, very prominent. Now, as Dr. Tada and Dr. Palin has said, that healthcare access often reflects social inequalities. Now, where we have the affluent section, which is covered by the private insurance companies, we have the lower strata. Many of them are covered by Ayushman Bharat. Why I'm using the word many? As per the government scheme, all of them should be covered. But many of them are not aware as to how to avail these. Even if they have the Ayushman Bharat card, they do not know where to go because the awareness is not there. Now, what they do is they end up going to a private hospital, where private hospital, it works for profit. There's nothing wrong in it. Even after having the card, they end up paying from their pocket, where that is why in the Northeast, the out-of-pocket expenditure is very, very high. Now, as, ma'am, you are from the social justice sector, what the other initiatives that can be taken to empower these marginalized communities, so that the healthcare access can be, improved, number one, and that adds directly or indirectly to the healthcare improvement of the parameters of the region.
Thank you so much. Distinguished panelists, the viewers, I would like to draw your attention to, besides I would be answering the questions as well, but I would like to draw your attention to one specific problem which I work on and my team works on, the ministry works on, is the drug addiction, which is very prevalent across the country. NER is not an exception. That's how I would like to put it. So just to answer first your question regarding the Ayushman card.
The microphone.
Yeah. Now, am I audible now? Yeah. So the Ayushman card, I think yes, awareness is required, but one simple thing is any government hospital would be having the information about it. There's a list of empaneled hospitals with the NHA, National Health Authority, and any patient is, can go there and do the needful. And there are people specially trained to handhold the beneficiaries who would walk in to avail this facility. Now, this is what has been prescribed, and this is what in the scheme, and this is also happening across because we have lakhs of beneficiaries under NHA. And but having said that, there are always certain issues that between the provider, the government. The government thinks that the government is giving these benefits, but the beneficiaries are not able to avail those benefits. There is a gap, and how do we address that? One definite thing which is coming across is lot of awareness generation. Awareness about everything. In fact, when I talk about de-addiction, in fact, I would rate it as the most important factor that has to be there in any service delivery. Otherwise, the people would not be aware. So I would like now, regarding the de-addiction, which I would like a special focus. In fact, I made a request to Mona Lisa that I would like to be a part of this session because I would like to talk about de-addiction. Is that the first time in our country we have done this national comprehensive survey. Okay, before that we did not have any figures. There was only an assumption that there's prevalence of drugs in the country, and perhaps it is more in Punjab, or perhaps it is more in the northeastern region. There were no statistics. There was no evidence. And for us who are working in the health sector, the evidence-based, evidence is very important. So when this survey result came, startling factors are that there are more than 7 crore users in the country. And out of the 7 crore users, 1.2 crore users are children who are below 18 years, right? And there is prevalence across the states. And there is a prevalence between 10 to 75 years of age. And there is usage of all substances, starting from alcohol to opioids to cannabis to amphetamine stimulants or inhalants, you name it, that is there. So I would now come to the inequalities. Does it reflect social inequalities? Yes, in fact, they are like,
they are quite related, okay, and it's also vice versa. And so we are not exactly talking about the marginalized communities, I'm talking about the social inequalities.
Or the economic inequalities, or the geographic inequalities. Like say, if we talk about the northeastern region, what do we have? We have borders, we have international borders, and we have there's a little stigma associated with the substance users and perhaps with the geography. And there are certain boundaries. There is a certain geographical isolation.
All these factors do have an impact on the healthcare access. That is for sure. That's a fact, and we need to work around that. Now, the second thing is that, so what should we do to remove these? Okay, that is where I think, besides the medical fraternity, where all the experts are present here and many more who are not present here, what the government does, that is very important, and government will have to be sensitive. Now, when we work on the health sector or any sensitive sector like de-addiction, so it has to be, the approach cannot be any more individual based or organization based or a government or a department based approach. It has to be a completely community based approach. There has to be a community ownership. Even to remove the inequalities, I feel like, some kind of a togetherness is required. So it cannot be like, one person giving or one government giving certain, certain benefits. It cannot be anymore like that. This I have seen particularly working in the de-addiction sector. So coming to what government has to do, or what government is doing to remove these access to the healthcare, to remove these inequalities to the healthcare. So if, when I now come to specifically northeastern region, we have about 100 de-addiction centers which are set up by the government, either the state or the central government, but supported by the central government here, which give free treatment and rehabilitation services. Now, when we talk about treatment and rehabilitation, I am talking about the stage 1, is, outreach, or rather preventive education, and then outreach, then identification, then the primary counseling, group counseling, family counseling, then detoxification, and then treatment. Then if there is any relapse or prevention of relapse or dealing with the relapse, then once the person, overcomes the problem of addiction, then what kind of support is required for the person to be integrated into the social fabric of the country without any social stigma, without any isolation. Now, this complete chain is being provided by the government through these 100 de-addiction centers in the northeastern region, and we intend to have at least one in every district of the country. So that is one. And the second thing is that, as I said, like, women, if we take women, so when we talk about inequalities, so it's not just social inequalities in that sense, economic inequalities and women. Now, as it is, de-addiction is, has stigma around it.
Now, women in our country are believed to be like, cannot be taking substances, okay, socially, right? But that's not true. We all know that. That's not true. So first we need to accept that there is an issue there. And once an issue is there, then what do we do about it? Yes, we need to accept that there is a problem. And the survey also, like I have the evidence to say that, this is the kind of prevalence, okay, in women or in men, in the youth. So when we talk about women, so what kind of center should we have? So we are going to set up, and we have already set up centers for women, de-addiction for them, 3 in Manipur and 1 in Mizoram. So that is one way of, addressing inequality in a certain small way, but definitely, that is going to increase. But, I think the first step is the best step, and that is already done. And the third thing, inequality, is when somebody is incarcerated, somebody is put in a jail, or even under trial, you're under trials, you would know, right? They're not convicted, okay? So there are so many of them in the country. In fact, the prisons are full of, under trials. Like, and there is lot of, again, evidence I would like to put, there's more addiction in the prisons than outside the prisons. Okay, it's very shocking, this thing, but then that's a fact. Okay, and then how do we address this kind of inequalities? Like, are we not supposed to, treat prisoners or even the under trials the way we should be treating? Or should they not have access to the health care as anybody else does? We should, right? So, setting up of de-addiction centers in prisons. Okay, that is one thing which has been done. So, there is one such facility, not one such, like, in Nagaland we have centers in prisons, and we have written to all the DGP prisons in the country saying that, we would like to at least set up one center each in the central jails. Am I overshooting the time? No? Yeah, thanks. And then can anybody, can everybody will have the access to, come to a certain center to take a treatment? Is it necessary at all that we need to walk into a hospital or a medical facility or have a one-to-one interaction with any medical professional to get some kind of a service? That's not required, especially in the de-addiction field. Medication or the treatment comes at a much later date. What do we need to have first? Which I have seen with my personal experience is that what people need is somebody who they can go and talk to have the confidence to go and talk to a person openly about the problem of addiction which they are having, and with full confidence the other person would not stigmatize or other person would not reveal the personal details of the person. So that interpersonal confidence has to be encouraged. And there is a sense of, generally when somebody walks into a hospital, or especially say walks into a narco center, or walks into a TB center, or walks into a de-addiction center, okay? So generally the tendency is to judge the person, right? Even if anybody walks into a room, generally you have a look at the person and then see, you have formed certain opinions. How to not to form such opinions, especially with people who require some kind of positivity and kind of attention. How do we inculcate that? So we are working on the capacity building of everybody. As I think Professor Nalin Mehta has mentioned, how do we train everybody, even the technicians, the counselors, the nurses, the ward boys, whoever is working in the de-addiction center, individually, according to the skills they would require, and totally, that means as a group, as to how the attitude has to develop when a person, you're going to interact with a person. So there's a lot of investment by the government on the capacity building, and especially in the de-addiction centers, we have enrolled a lot of important hospitals and medical institutions like AIIMS Delhi, like PGI Chandigarh, and like the Tejpur Medical Hospital for the Northeast, and NIMHANS, and Professor Nalin Mehta is here. So I would like to remind you, sir, that, we had asked for, for his, for a proposal from them for setting up of a Center for Excellence, and that is a suggestion which came out of the Honorable Prime Minister's discussion with the Chief Secretaries of the states, where all the Chief Secretaries of the Northeastern states were
Just so
there.
that you keep smiling, we are working on it because this has to come in with the state government. So the
Yes.
nodal center will be set up at Nigrims. The
Yes.
DPR is ready, and we are in consultation with the Principal Secretary Health and the other state stakeholders.
Yes,
So we are working.
support you fully in that. And in fact, I have already talked to Professor Nalin Mehta, that the Principal Secretary Health,
Exactly. Sampath
and
was here
also the
today. We
Principal
could have-
Secretary Social Welfare, Mr. Sampath, and everyone. So we are going to tie that up, going to ensure together with the help of Professor Nalin Mehta
consider
that
it done.
the center
Yeah,
comes.
thank you.
Thank you so much. So these are the few things which I wanted to share. There's much more to talk about, maybe in a different forum. Thank you all.
That's one of the very important aspect that you have touched upon, is that suppose there is a de-addiction center being established that has to be manned by or operated by having a team where you have the psychologists or maybe somebody, ideally a psychiatrist, which is not possible practically. But we have a stigma that if somebody goes to a psychiatrist, I'm having a psychiatric problem. That is one of the major stigma that we really need to remove. Now, coming back to another very important aspect is the accessibility to the healthcare facilities in the Northeast. When you talk about the accessibility in the Northeast, awareness is lacking. Even if the awareness is there, because of the difficult terrain, the roads, and the transport system. There are instances where patient narrated from Arunachal, Arunachal being one of the largest states in the Northeast, in fact the eastern region, the difficulty is there when a patient, in some of the remote places, when a patient has to travel or a patient has to be transported from one part of the country, one part of the state to the nearest healthcare facility. I met a patient who narrated that he had to be taken to a center to get an ECG and an X-ray, chest X-ray done, because that is something which was advised by somebody. Now, he traveled half the day, reached the nearest center in the afternoon. By the time the facility was closed, he had to stay there, get the thing done the next day. The report was delivered in the evening. The consultation was done on the third day, and third day afternoon he had to go back. So if we look at the entire scenario or the series of events, 3 days for a basic investigation. Now, in this case, if at all we look at the loss that the patient has incurred, number one is the direct finances that he has lost, and if we look at 3 man-days gone completely. Now, in this case, IT would play a major role. When we talk about IT, it's the healthcare IT, and I would have loved to have somebody from the previous panel here to address some of the issues or maybe to put some of the inputs here. My question to Dr. Tada is how IT can be utilized, how we can leverage on the usage of the information technology to bridge these gaps.
Yes, I think unfortunately, most of the northeastern states, especially you talk about Arunachal Pradesh, I belong to Arunachal Pradesh, the sparse population and communication bottleneck, plus the uses of IT for enhancing the diagnosis and delivering the facilities have a very limited role because of erratic power supplies in the anterior places. Not to talk about anterior places, I lived in Guwahati for 8 years. 6 months back, I was just moved back to my place. And a city like Guwahati, I think the erratic power supply has been experienced. You can imagine the remote areas You know, though the Northeastern is called the powerhouse of India, today they spoke. In Arunachal Pradesh itself can generate around 56, thousand megawatts, which is supposed to be one of the largest in the country. But though we have generating power, there's no power supply because, so I think this limitation in the interior remote outpost using the IT is, I think I have to undermine. It's till now it is not practicable. Truth is bitter. I'm not blaming any government system or this thing, but I think it is not to talk about Arunachal Pradesh. You go to remote Assam, because I have widely traveled all the 8 states. Every hospitals I visited during when the director of National Health Mission for Northeastern India. So I know there's a limitation of the power supply. Then again, the manpower to interpret, incorporate is another major issue. Otherwise, it has a tremendous potential to bridge the gap, this kind of issues in the remote areas and the northeastern India still. We are far lagging behind. I think not to talk about northeastern India, and we had common review meeting in National Health Mission every year, every state we go. The major state, like I had been to many major states like Himachal and Chandigarh and Karnataka, even the remote areas, still they face the same problem. So you can imagine northeastern India, still we are far behind. Yet to go, long way. Thank you so much.
Thank you, sir. When we talk about healthcare, we divide it into 3 aspects. One is the preventive, the curative, and the rehabilitative. Now, when we talk about the preventive health, now people did not understand the benefits and the other aspects related to preventive health. Now, over a period of time, people have realized that Ayush kind of systems can be utilized in the preventive aspect. My next question is to Dr. Kishore, how Ayush can be integrated into mainstream treatment line, and what are the benefits that can be reaped from this for the patient?
Already I have told regarding mainstreaming, I think so. Okay, regarding preventive healthcare, if you look at the health scenario of Northeast, at the topmost there is medical colleges. Then we have the district hospitals, and then we have the PHCs. Always the rural population, they come in contact with these PHCs or other centers below these PHCs. So these PHCs has to be integrated with Ayush services, so that Ayush professionals are recruited over there, and then they can disseminate the message regarding preventive healthcare through Ayush. And second part is that medical colleges are coming up in entire Northeast, but if you talk about Ayush colleges, they are very limited. So the number of Ayush professionals are very less. As you know, there is always a crunch of manpower in the entire Northeast. So the sad reality is that many times our Ayush professionals have to fill up the shoes of conventional doctors. That's why this thing has to be removed somehow, so that Ayush professionals can do their own pathy and teach the public regarding preventive healthcare. Next is we have to be a part of every public health campaigns. Many programs are running on, like public health outreach activity through National Ayush Mission, Ayurvedya, means a program for healthy lifestyle for school-going children. These kind of programs are coming on, but we have to have more programs like this. And next we have to train the local health workers like MPWs, like ASAs, and other local people, so that they can identify medicinal herbs and know about the Ayush lifestyle, and they can disseminate among the common masses. And we have to also ensure regarding public-private partnerships, so that Ayush healthcare setups are built in remote areas and they can access to healthcare facility through Ayush. And lastly, one thing is very much important. Government has to support us, because many times this is not seen. Our government has to support us, so that capacity building can be done lot of Ayush doctors can be recruited, and even Ayush melas can be held in places so that we can disseminate this message, sir. Thank you.
Yes, in continuation to your inputs, another aspect which is the rehabilitative part. Being an orthopedic surgeon, Dr. Tonkeswar Barua would definitely need a lot of rehabilitative services, especially from the allied health sciences. Would like to request you to throw some light on the rehabilitative aspect, number one, and how Ayush streams or facilities can be integrated in your practice to help the patients.
So I love this question. One example, I am a spine surgeon. I am working in Safdarjung Hospital. We see lots of patients. Now, I was writing medicines right or left and advising surgery, everything. But one day I catch up with very big pain in my back. So I was very reluctant to take too many medicines that I used to write. I took 2 or 3 medicines. I had no recovery for 2 to 3 weeks. Though I did my MRI, it came out to be 2-3 discs because we do long surgeries. So I was a regular yoga man. I was doing yoga for 2 to 3 years before that. So one day after maybe 2 to 3 weeks, I went to yoga place with the old uncles. And after doing yoga, initial 2 days, it was severe pain, but I keep continuing. So after 4 or 5 days, I started recovering. Now, second part, I am from I'm from my village in Lakhimpur district in Assam. So he was having back pain. He was not getting relief for long with my advice. And he said that your advice and treatment is not going to help me. I used to do this asana, that is Tadasana. Tadasana means standing and stretching the whole body. And do this. And immediately I started advising to all persons who came to meet me in my village. And next visit, they said this is doing wonder. In fact, lots of persons from ministry, they came to me. I used to advise Tadasana to almost all of them. Believe me, most of the patients got relieved from that asana. Now, before we had integrated service, we are lucky in Safdarjung Hospital, our Honorable Minister, Sarbananda Sonowal ji, in his Ayush Ministry term last year, he had opened a big integrated center and with some emotional attachment as he is from Assam. So I used to send almost many patients to that center, and after some months they said that yes, we are getting relief, specifically those patients who are having non-specific back pain without any relief. So I usually send patients to yoga center. Now second part of the question, rehabilitation. When I was doing post-graduation, my professor Lokar sir from Dibrugarh, he said, orthopedics is not only surgery. 60% is rehabilitation and 40% is what you said, medicines and surgery. So I kept in my mind, so maximum time our focus should be in rehabilitation. Yes, there are another big department that is known as PMR. Most of the people does not know. In fact, the departmental doctors also, they practice like another surgeon, but I should not say like that. Still, in hospitals like AIMS, in Guwahati we had, probably NEGIMS, in our hospitals we are having a big department of rehabilitation and PMR. So I request that all medical colleges should have knowledgeable and good full functioning PMR department in all district medical colleges coming up. And last suggestion I used to say, like he said, at least in CSC level, every CSC centers or not at least in CSC or district or block level hospitals, one physiotherapist should be appointed, because most of the patients, they used to be operated, they're lying down in the bed for long, they don't know that I have to walk. No one says that you have to walk, but those patients, they could walk immediately, maybe next day. Thank you.
Now, another aspect which is very important in healthcare is the role of the private players. Now, if we look at the number of beds, which is on the higher side for the public healthcare system, if we look at the money being spent, which accounts for somewhere around more than 75% of the total healthcare expenditure. Now, these private players will have to come up with a lot of innovations to stay in the market, to place themselves in the market. First, there's cutthroat competition, and a lot of innovations need to be, or innovative ideas need to be integrated in the healthcare practice. Dr. Palin, being one of the entrepreneurs, leading entrepreneurs from the Northeast, my next question is to you, sir. What are the initiatives that need to be taken by the budding entrepreneurs in healthcare?
Thank you. The disease burden of the country is so high, and modern medicine cannot handle it. So Ayush has to come into the picture. World Health Organization has already warned India that 63% of our deaths are due to NCD, non-communicable diseases, which are related with the lifestyle diseases. So the number is so high, and the India cannot handle it. Economy is losing, and on the other hand, this Massachusetts Hospital and the Benson Henry Institute has already demonstrated that only through yoga and meditation, 43% of the healthcare expenditure can be reduced. This is a great finding. The services of Ayush, like yoga, meditation, food, spiritual teaching, and on top of that, the other lifestyle related, like menopausal trip, because women suffer a lot during the menopausal period, corporate wellness, stress management, and of course we can add some other areas like hyperbaric oxygen therapy, or beauty, and even senior stay, because they suffer a lot. So for this wellness program, if we fuse, coexist with the allopathy, I think we can prevent the diseases. It is already proved that yoga and meditation for 15 days increase the length of the telomere. This was demonstrated by a Nobel laureate, and it increases the length of the telomere, which is at the tip of, it is a protein particle at the tip of the chromosome. The length of the telomere is related with immunity and longevity of the individual, and this is already demonstrated. And also the same thing with food and other exercise. So what I would like to say, India's disease burden is so high, and we have to coexist with the Ayush and allopathy. It is already done in AIIMS. China has already integrated in 1950, and their traditional medicine is integrated with the modern medicine. And by doing this under PPP mode, because it should be profitable, it should be accessible, it should be feasible, and the area, this is called wellness tourism. Wellness tourism, the market is more than the medical tourism. Medical tourism is treating the patient. Wellness tourism is prevention of diseases. And North America is the capital of wellness industry. Asia Pacific is fastest growing. India's contribution to wellness is very low. It's around 0.25. India is targeting for 3 to 4% contribution, global contribution. That's why Honorable Prime Minister has already announced visa for the Ayush visa is already announced. So that is how it is being integrated, and many other, and there is the instruction from the NITI Aayog also. Ayush and allopathy should coexist. Even our MBBS students, there should be interns should be sent to Ayush hospital for exposure for 15 days. This is the the intensity of the policy they have already created. And by doing this, we have Northern India language, English-speaking language, beautiful sceneries, weather, and we have all the opportunities for developing Northern India as the wellness industry, wellness tourism destination of the world. And that is how we can reduce the number of NCD, quality of life will be increased, and healthcare costs will be definitely reduced, and productivity of the individual will be increased. And it is possible if there is a proposal from this government PPP mode. We are ready to extend. We are working on that.
Yes.
This is a huge potential for the this entrepreneurs. Thank you.
My last question to the panel, to Nalin Mehta, sir. So NEGRIMS is doing a phenomenal job when it comes to the treatment part, the education part, and the other things. Would like to know what other initiatives can be taken by your esteemed institute for the promotion of healthcare in the region. After that, we would like to have a short answer from you. After that, we'll open, because we are having somewhere around 14 minutes, we'll open the session for question and answers.
Thank you. So I think part of this I have already addressed when I spoke of what NEGRIMS was doing to address the unique challenges of the Northeast region. One thing we ensure is keeping up to date and to ensure that there are continuing medical education and continuing nursing education programs, so that every professional is not just up to date with the standard of care that has to be provided, but we ensure the highest standards of healthcare delivery that is given to the patients. Now, in addition to that, we adopt the latest technology which is available, rather than hinging on something which is either obsolete or outdated. And we are very, very open to collaboration. I think time has come now to realize that there is nothing that you can do alone. It has to be done not just in collaboration, but in keeping in mind the preferences of the patients. And I'd like to, on the side, add, apart from the fact that implementation research is what we are focusing on currently, because there are a whole bunch of problems which the people of the Northeast are suffering from, which have solutions, but those solutions are not reaching the patient. In fact, I gave these figures in an earlier panel on the women empowerment. 287,000, I mean almost 3 lakh women die every year of complications during childbirth and pregnancy. And all these complications have treatments. Now these women unfortunately die because they are not able to get the treatment. We have around 7 million children dying, out of which 3.1 million are infants, from preventable, treatable diseases. And the reason being that the treatment is not made available to them, or they cannot reach. So I think how to implement, identify the problem is identified. Identify the solution exists. Now how do we take the solution to that area? Either because of the terrain, either lack of awareness, there are a whole bunch of reasons. So I think that implementation research is what we are focusing on. And I want to touch upon this Ayush business. It is very unfortunate, and I don't mind being quoted. And once I was speaking to the Honorable ex-Minister Sarvananda Sonowalji, it is shameful that we call our Ayush medicine as an alternative system of medicine. The modern medicine, of which I am a very proud graduate and postgraduate, is 200 odd years old. The traditional systems of medicine in India are over 3,000 years old. Ayurveda, Siddha, Unani, etc. And we call them alternate. So I think when we talk of preventive and promotive stuff, these are part of the patient preferences. So we have gone one step further. We had a consultative meeting which included traditional healers in Shillong, especially for cancer care and tuberculosis elimination. You were there, I think, in that anti-TB, some of the representatives. You were there, right? So we called the traditional healers also. And in consultation with them, we decided how to identify and how to send patients to allopathic hospitals for DOTS treatment, because that could not be done through the traditional healers. For spreading awareness, we are reaching out to religious leaders, church leaders, temple leaders, and even Maulvis from mosques, because people go and listen to them. So for cancer prevention, for creating awareness, we ask them to say a few things and then send the patients to us. So I think a lot can be done in consultation, and every human being who can spread the word towards good health probably is as good as a physician, whether it is official or unofficial. So I think that probably sums it all up.
Yes, thank you, sir. Now we'll open the session for question and answers. Dr. Pragyan had raised his hand. We'll come to you, ma'am.
So I am Dr. Pragyan. I am Dr. Pragyan Sharma. I am a senior neurosurgeon at Safdarjung Hospital and colleague of Dr. Barua. I belong to Guwahati, Assam, my native place, and that's why I'm very keen to know what is happening in the Northeast. So my question is to Dr. Mehta, sir. So yes, NAGRIMS is doing a phenomenal job. The infrastructure has come up in a big way. It has almost all the modern gadgets, adequate number of beds. Many complicated diseases are being treated. But ultimately, to deliver the healthcare, you need trained personnel. I mean, trained manpower is the main engine. So what I have seen is that the attrition rate among the doctors, among the faculty members who join NAGRIMS is very high. It's a cause of major concern. I can tell about my department, neurosurgery. I know at least 5 or 6 of my senior colleagues who joined there as a faculty and ultimately left NAGRIMS. So what can be the cause of this major attrition rate, and what are the steps that can be taken to prevent it?
Excellent question. In fact, I think almost in the last 5 years, we have lost more than 25 faculty members to other institutions, mainly to AIIMS Guwahati and some to a few other AIIMS. So, and this is an issue which is plaguing a lot of state governments. Wherever the names comes up, people from the state government leave that and go to AIIMS, but for NIGRIMS it is kind of special. So what we have done, in fact I have been very aggressively shouting for the INI status for NIGRIMS, and this is being pursued very aggressively, not just by us. There is a political leadership also which is very keen on this, and our Honorable Health Minister has also assured us that we will work on it, and I think cabinet note is ready. We might probably get that status. The minute you get parity, there will be an advantage, because when NIGRIMS was initiated or established in '87, it was along with AIIMS New Delhi and PGI Chandigarh on the same lines. And somewhere down the line, it got a little downgraded, I think after the 6th pay commission. People leave NIGRIMS for a better pay package, better allowances. So career progression, everybody would love to. So the newer AIIMS, despite being a central government institution, we do not have parity with them. So anybody who wants more wishes to join some of these. Unfortunately, the newer AIIMS are not up to the mark as yet, because their infra is also developing, they are getting quality people, but people leave to look for a greener pasture. So what we are doing is we are aggressively advertising to recruit, and we are working to retain, and in order to retain them, we would also have huge benefit if we get an Institute of National Importance status, which I am hopeful should be with us in the next couple of months. But I'm very happy that you asked, and I am absolutely open to conceding that we are losing a lot of good people, not just doctors, even a few nurses have left, and majority of them to AIIMS Guwahati. So I think this is a matter of concern. I'm glad you raised it.
Yes. Okay, ma'am.
Thank you. I'm Dr. Jubilee Porcasto, scientist AF from DRDO. I belong to the Institute of Nuclear Medicine and Allied Sciences. In continuation with what our honorable panelist has mentioned, I just wanted to bring before you, as a DRDO, what technologies we are already having and what we are already doing for Northeast India. Just to begin with INMAS, this is the Institute of Nuclear Medicine and Allied Sciences, we had a Orunodaya program, where Dr. Folin talked about adoption of villages. And in Tawang, Y Junction, and Salary areas, we had adopted villages for healthcare, and we did our best under that project, under that program. And in future also, we have lots of things in mind. And as Dr. Nolin said, it is a moment of collaboration. So if any of you think we as a DRDO can do more, definitely we can join, and I am sure our organization, our chief will be able to support this whole thing. Second, we have a lab in Tejpur called Defense Research Laboratory Tejpur. Okay, so there we are working we have our sister lab also in Tawang and Salari. So for that we are doing regular, we are having our scientists posted there, and we are doing technologies for skill development, for Kisan Jovan Vigyan Mela we are organizing over there. And this is even the bio toilet we have established that, because I understand prevention of groundwater contamination is one of the technologies, and we have the technology, so already we have done a lot, and further we can be done. Coming to telemedicine that Dr. Kishore Das just mentioned, we have a lab in Bangalore called Defense Bioengineering and Electromedical Lab, that is DEVEL Bangalore. We developed the telemedicine. We have the very advanced telemedicine system, and we develop it for our forces who are posted in the remote places, also for the Navy. And that technology definitely can be adopted for, I propose it can be taken for Northeast India also. And coming to the healthcare situation, I belong to the remote village in Assam that is called Mohishashan village in Karimganj district of Assam. I can just mention one of the incident where I lost one of my cousin because we could not take him to the nearest medical facility. You know, in Borak Valley, it is around more than 44 lakhs are the population right now. And mostly we are dependent on only one thing, that is the Shilchar Medical College, which is little bit advanced. And coming to the Karimganj hospital, I can just tell you, even the ICU is not developed. So it is a situation, it is a very, very bad medical condition over there. So that should be taken care of. Coming to the erratic power supply, it is definitely, it is a continuous problem, especially in the remote village. You know, in 2015, my village got for the first time an electrical connection. While I was studying under LAMP, you know, this is the situation I had to face. Now coming to the telomere and other things that you mentioned, the end of the chromosome, it is the cap at the end of the chromosome, and at every cell division we lose a part of that, and that is the reason we get aged and all these things. So coming to that, I can just request you that there are lots of antioxidant and other medicinal and fruit plants. And this can be, definitely should be explored for further. These are indigenous plants of Northeast India, which are actually, it cannot be found anywhere else in the world. And this is talking to the traditional system of medicine, I just request again, I wrote a book, actually it is published by Lepp Lambert. It is, I named it as Medicinal and Aromatic Plant Resources of Northeast India. So that also give just a glimpse of what resources in terms of medicinal and aromatic plants we are having. So that's all from my end.
Thank you, ma'am. We will definitely make it a point that we'll get back to you on this, many of the points, and some of the inputs which are very, very valuable, we will try to incorporate. Yes.
Hello, good evening to all. I am Mr. Nibir Burman. I'd like to address my question to Dr. Kishore Das. We always look Ayurveda and Ayush as mainly as a preventive treatment and a healthy lifestyle. It has also been accepted by the panelists present over here. Dr. Da, I would like to ask that, you know, to enlighten this crowd, that what is the vision of Ayush in the coming years in penetrating the public health delivery through the Ayushman Arogya Mandirs and the Ayush wings to cater to the rural populations in the Northeast. That is number one. And I would also like to give some light to this crowd of the Panchakarma line of treatment and its role in strengthening the public health delivery in a holistic manner. That's it.
Okay. Now coming to the Ayushman Arogya Mandir. Okay, I'll make it short. Coming to the Ayushman Arogya Mandir, we have nearly established 500 Ayushman Arogya Mandir in the state of Assam. And almost all the 500 Ayushman Arogya Mandirs are functional. And these Arogya Mandirs are equipped with all Ayush doctors. Then there is a yoga unit over there. So these are working very nicely for preventive as well as promotion of Ayush. And secondly, regarding your second question, regarding Panchkarma. Yeah, Panchkarma actually it's a very nice procedure of Ayurvedic system of medicine where there are 5 procedures regarding detoxification of the body, and these Panchakarma centers are going to be established. Actually, it is in Government Ayurvedic College and most of the Ayurvedic colleges, and it is going to be established in all the districts. Nearly 18 Ayush Wings has been established all over the state of Assam, and these are equipped with all modern tools related to this Panchakarma. So within a span of few years, this will be very much functional and we will be able to provide these Panchakarma services to the state of Assam. Okay, thank you.
Good afternoon, good evening to everyone. My name is Prashanta Das, founder of Dr. Hippo Healthcare Private Limited. I do take care of the logistics in healthcare system. Okay. And apart that, I do promote education by the name of Digital School of Delhi. My question is, it's open for the panel actually. I do belong to Assam. Okay. So my question is, whenever I visit Guwahati, then I can say
Many people used to travel to south for a better treatment. As I'm not talking about rural places, I'm talking about only Guwahati. Okay, when Guwahati is a city, there are so many hospitals, say Apollo, GNRC, so many good hospitals over there. So is it a belief system that people think that South can provide better care? Or is it the lack of infrastructure that people are compelling them to travel to South? So I'd like to know to provide my service as well. That's why I'm asking for that.
Okay, can I answer with your permission? Yes. Many of us think, and when it comes to Assam, many of us think that better services are provided in down south. Especially people from Assam, we have a notion that better orthopedic services are there in Patna. Yes, it was. Dr. Mukhopadhyay was there.
He's no more. Long back. Due to age, he retired and then he expired. Now, but the trend has continued. Sir would agree that even I know personally, there are cases who went to Patna, got down from the railway station, I don't know where they went. It is Patna, not to that particular hospital where Dr. Mukhopadhyay used to operate, and came back to hometown Guwahati with a lot of complications, maybe with deformities or maybe with non-healing, or the bones did not unite. So now, what can be done? This can be, there are many hospitals which have come up. Even Apollo has taken 2 hospitals in Guwahati, offering similar facilities like Indraprastha, Hyderabad and Chennai. But we do not want those doctors coming to Guwahati and giving the treatment. We do not want that. We want that particular doctor to give us the treatment in that particular hospital. So these are the aspects which we really need to work on. We would have some detailed discussions with you. If at all that can be addressed, definitely we would really be very happy.
There was a little emotional component in what you were saying. To cut the story short, every patient has a preference and a right to go where they wish. There are institutions and cities and doctors who have made a reputation. Like a whole bunch of people go to CMC Vellore for cancer treatment, or even otherwise. They go to AIIMS New Delhi, they go to Patna. In fact, Dr. Mukhopadhyay's son is still a leading, John Mukhopadhyay, probably one of the best orthopedic surgeons in Patna. People would still go to him. The issue is, when you establish an institution or a healthcare facility, you have to work and your results have to show, and you have to disseminate those results, ideally through good papers, publications, and build a reputation. Once you have a reputation, people will start flocking. So if somebody wants to go to CMT Vellore, it's a very, very high quality care area, so why not? So I think we have to come up to those standards rather than say, why are people going elsewhere?
Yes, to wind up, what I would request the panelists is to write a few points, create a summary of the points that were discussed today, in the session and share it with me maybe, or maybe with Ms. Namrata, so that we can prepare a concept note and a summary note and then submit it to the organizers. That will be shared with the ministry.
So in that council meeting, I would request the panel members to include what is the immediate scope for the entrepreneurs to start up, or the startups like us to collaborate with. In those immediate scope for business, for the entrepreneurs that from a startup like me, how can I collaborate with the Ayush, like any institute? So it should be included in those points. My request is to the panel.
We'll do that. We'll do that.
So once again I will be taking, in continuation of the collaboration proposal, what I say ki, in our institute, we have a BSL-3 facility. And all of you might be knowing there was a drug during the COVID period that is 2-DG, 2-deoxy-D-glucose, that we got emergency approval. So we have a capacity of doing research on viruses. In the BSL-3 facility, we have expertise also. So in that case, if any kind of like viral research support is there.
Sorry to interrupt. I think we are just running out of time.
Thank you, sir.
Just wrap up soon. Thanks.
Okay, thank you, ma'am.
Thank you so much. Indeed, a thought-provoking session, and thank you so much, panelists, for joining us for this wonderful session and sharing your insightful knowledge today with us. Well, indeed, when it comes to the healthcare and education of Northeast, there has been a significant paradigm shift in both the sectors, driven by various factors such as technological advancements, government initiatives, and community-driven efforts. There has been a steady improvement in healthcare facilities, with more hospitals, clinics, and specialized medical centers opening in the region. Before we wrap up, coming to the conclusion of the session today, I request Dr. Borua ma'am to kindly do the honor of felicitating our guest with gifts as a token of appreciation, please. Thank you. Ladies and gentlemen, a great round of applause for our panelists here. Yeah, if we could just come and for a group photo, please, a few.